We've got some rapid fire success stories from 3 different teams. Again, we'll have a bit more time to ask questions about these later, but if I can invite Chris Jones from Guildford up, who's going to talk about enhanced recovery and their successes and sustainability in reducing length of stay in their hospital.
So hopefully I can see my slides over here.
You've got to click on this. You've got to click on.
Oh, do I? Oh, sorry. Ah, perfect. So yes, Chris Jones, an anaesthetist down in Guildford. Been asked to talk about enhanced recovery. Now, I'm sure you all know a lot about enhanced recovery. I'm teaching you how to suck eggs. There are lots of different names, but ultimately it's come down to this man, Henrik Kellett, who's a colorectal surgeon from Denmark. And he really revolutionized how we look after patients in the perioperative period. In the late 90s, when he produced this paper, the average length of stay, certainly in this country for colorectal resections, was between 10 and 12 days. And in this paper, it was a median of 2 days, using the sort of the elements of early mobilization, early feeding, and importantly about thoracic epidurals. I'm sure you've seen these sorts of slides looking at all the different elements. I'm not going to go through all of them, but it highlights the importance of team working from the pre-operative care to the post-operative on the ward, but also obviously with anaesthetists and surgeons working closely. I've heard anaesthetists say, well, actually all we do is see patients in theatre. The ones here and the elements that have stayed black are the ones that actually we can directly involve. So why do we do enhanced recovery? Well, there's lots of different reasons. One of the main reasons, obviously, is length of stay. That's the sort of the highlight. But actually, it's much more about improving outcomes, both short-term and long-term. Good evidence now for long-term improvements in survival rates. But actually, the real key is decreased complications, I think. I would hope that you would have seen this paper by Curry back in 2005, and it was a bit of a game changer for me. Huge study showing that actually if you had a complication post-operatively, that was the main determinant of sort of your longer-term survival, had a huge impact by up to 69%. I maybe naively thought that somebody who had a chest infection would have a few days extra in hospital, few doses of antibiotics, and then they'd just be back on their way merrily along. But actually, no, it has a huge, huge impact. So overall, improved patient stay, length of stay, improved patient satisfaction, reduced costs, and improvements in morbidity. So a little bit about our experience. I come from Guildford. We are a funny little place. We're a little DGH with 500 beds, serving a population of about 300,000. But we're also a major cancer centre, serving a population of just over 2 million. And a number of different high-risk specialities, including OG, hepatobiliary. We're also one of the busiest robotics centres in the country, but we've also been recognised as a centre of excellence for enhanced recovery, and we're an early adopter for enhanced recovery. We also run quite a few different fellowships, take this opportunity to advertise, including major cancer ones, and jointly with the Marsden, which is an exciting new fellowship. We've been sort of leading the way, particularly with colorectal surgery. This is a slightly old slide, but we've been consistently at that end. We've also had a number of different sort of publications, including the 24-hour or 23-hour stay laparoscopic colectomy. We've also published our esophageal work. We've also adapted it to emergency laparotomies. We've looked at new specialities such as head and neck, and also we were the first to do an RCT and open liver resection, which I will just pause on slightly. At the time when we set this trial up, there were no liver guidelines, so we sort of bastardized, for want of a better word, the 2012 colorectal guidelines. Interestingly, we realized that actually the vast majority of those would be considered now standard care, such as antibiotics, warming, etc., etc. So when we randomized to the 2 groups, every patient had a standardized anesthetic. We didn't change the anesthetic. We didn't change the surgery. All patients had epidurals. So in essence, the main differences were the preoperative education and counselling, carbohydrate drinks, oral nutritional supplements. The epidural in the enhanced recovery group came out on the morning of day 2, rather than day 3, 4, or 5, which was our sort of current practice. I say early mobilization is actually more intensive mobilization. They got mobilized twice a day by the physiotherapist, and they also got some gold-directed fluid therapy in ITU. Very similar groups, but interestingly, there were significantly more malignancies in the enhanced recovery group. Unsurprisingly, they also had more preoperative neoadjuvant chemotherapy. They also had more major resections, although it wasn't quite significant. But despite that, a dramatic reduction in length of stay from a historical 9 days down to 4. Also, they were medically fit for discharge, and we assessed that using a blinded independent assessor. Because we didn't change our actual sort of surgical techniques, funnily enough, there were no differences in the sort of liver or surgical complications, but there were a huge reduction in our medical complications, which, as we've said, is very, very important. Our pain scores were significantly better throughout the stay, particularly on day 3, where you have 2 groups, one with an epidural out, they're independently mobile, catheters out, and they got better pain scores than the patients with the epidurals that are in. We also used EQ5D to look at our quality of life just over the first month, and it shows a sort of less of a reduction in quality of life, which also looks very similar to the ERAS Society logo there. We did a cost analysis, which despite buying a Lidco Rapid machine, plus the cards, oral nutritional supplements, etc., extra physio sessions, we still managed to save about £1,000 per patient. And at the time, we were doing about 120 a year, so significant savings. It's also sustainable. You can see our pre-trial data 9 days down to 7 for the standard care. Our enhanced recovery pathway was 4 days. And we repeated this a couple of times in the last few years. And it slipped slightly to 5 days, but it's still sustainable. Now, you'll probably see similar sort of slide, but for enhanced recovery, I think particularly as an anaesthetist, or as an anaesthetist, the key is getting the analgesia right. If you can get that right, with minimal side effects, you can really get patients up, eating and drinking, and mobilizing. And I think mobilizing is probably the really number one thing. If you can focus on one thing, it's the mobilization. How you do that is obviously up to your sort of local protocols and what have you. It is always a little bit of a compromise on how you do it. There's always going to be downsides. With the original enhanced recovery pathways, it was all about the thoracic epidural. We showed in this study that actually for laparoscopic surgery, it's actually a bit of a disaster. It slows the patients up. What was interesting, though, is that despite worsening pain scores, a morphine PCA group didn't show any sort of slowing up of outcomes. But the proof in the pudding is in the eating. This video is a patient who had, from memory, a right hemicolectomy. This is about an hour post-op in recovery from one of our enhanced recovery courses where we do live anesthesia and live surgery. And it shows that really early mobilization in the recovery is possible, admittedly with a little bit of help for this one. And then this chap had an anterior resection. Again, this is about an hour post-op in recovery, just a couple of beds down. In fact, he's slightly more steady on his feet than the videographer there. But it's not just colorectal surgery. We also do a lot of robotic cystectomy. So again, laparoscopic work. We use spinals for these. We do 2 every Friday. This is post-operative day 1, again showing that they can be mobilized really quite quickly. One of them slightly more happy than the other one about that. And it's not just laparoscopic surgery, it's obviously major open surgery, OG probably being the biggest operation that esophageal resections that we can do. And we've invested in Hill-Rom beds, these beds that you can get sitting up like that. You can also help them stand with that, with these beds. Aids to mobilization, silly things, non-slip socks. I mean, they're not new now, but chest drains that you now don't have to clamp, they can be inverted. If you put all the drips on one stand and actually chart them in the drug chart that they have to mobilize is the key. So esophageal surgery is not a barrier to mobilization. It is sort of fairly heavy on man/woman power. They do take a lot of physios. They tend to have the The chest drains put in their back pockets, but you can mobilize them. This patient, again, is another esophageal resection. He was a redo, and I forget exactly why they had to go back in, but you can see that he's still on a ventilator with a tracheostomy, and despite that, you can still mobilize. There's no real barriers to mobilization. So, in summary, we've used enhanced recovery pathways for we were early adopters, so from about 2003. They're very much a sort of standard of care really now for us. It does take quite a long time to develop, and you need to do that with your teams. But ultimately, with a good protocol and an established protocol, that can empower staff, particularly on the ward, to be able to, with confidence, take out epidurals, take out catheters, take out whatever. And ultimately, you need to audit what you're doing, and that's where PQIP can help, I think, to actually show that you are doing what you think you're doing. Thank you. We're going to stay up here.